Hello everyone, this is our second lecture on fluoroscopy and interventional imaging. After today's lecture, students will know about fluoroscopic imaging chains using both analog video recording and digital video recording. We shall learn about flat panel systems and the difference between image intensifiers and flat panel detectors. We shall also learn about peripheral recording equipment used in fluoroscopy and explore a few more fluoroscopy configurations. Students will learn about real-time imaging modes. We shall also learn about image processing tools used to reduce patient dose and the trade-offs with image quality. We shall finish with dosimetry and patient skin dose indicators. We shall start with the fluoroscopy imaging chain. The imaging chain consists of the image intensifier, the optical coupling system, the video camera, analog processing, and TV displays. We shall look at the optical coupling system first. The function of this system is to couple the light image from the output of the image intensifier to the video cameras and to set the proper light level for the camera, which effectively sets the noise level appropriate for the imaging task. The coupling system is often made up of fiber optic cables or an optical coupling system. Optical lens systems are made up of the collimating lens that shapes the divergent light from the output phosphor, the aperture that limits the amount of light reaching the video camera, and a lens to focus the image onto the video camera. Let's look at each member of the lensed optical coupling system in detail. An adjustable aperture couples the image intensifier output light to the video camera system and controls the light exposure to the lens. As the aperture size is changed, the amount of light that gets through the lens is also changed. Aperture size is specified by what is called the F number. F number is a number used on camera lenses. It is the ratio of focal length to aperture diameter. F number is inversely related to aperture diameter, while image brightness is proportional to aperture diameter squared. Aperture and gain are related. Lowering gain by making the aperture small leads to increased patient dose. The next part of the optical coupling system is the video camera. Video is important for real-time visualization of the image intensifier output image. A video camera is shown on this slide. In older imaging systems, a video camera captures the image at the output of the image intensifier and converts it to an analog electrical signal that conforms to a recognized video format. These video cameras were made of photoconductive target materials like antimony trisulfide, lead oxide, and cadmium selenide. They were collectively called vidicons. Analog video systems suffer from lag. Lag describes the speed of the response of the video camera to a changing signal. High lag can result in blurred images of moving objects, but noise will be reduced through temporal integration. Video cameras transfer the image at the output phosphor of the image intensifier to a video display system. The video display system uses 525 scan lines to display images on a screen. The display rate is 30 frames per second, so each image frame is displayed for about 33 milliseconds. Scans are interlaced to reduce flicker with even and odd scan fields intertwined. In standard video displays, the time per scan line is obtained by dividing time per image frame of 33 milliseconds by number of scan lines of 525. This gives 63 microseconds. High line rate video displays use 1023 scan lines per frame. This slide shows the scanning scheme used by the video camera for the image intensifier output target and for the TV display. The electron beam at the output phosphor produces light. The video camera scans the output phosphor in raster fashion, and the beam current is modulated by the video signal. Higher beam current at a given location results in more light produced at that location by the monitor phosphor. The raster scan on the monitor is done in synchrony with the scan of the TV target. This slide shows the modulation transfer function for an image intensifier imaging chain. Film and optics have the highest modulation transfer function, while TV systems have the lowest, demonstrating that the TV system is the weakest link in an image intensifier chain. So far, we have talked about analog video camera acquisitions in the last few slides. We shall now replace the analog video camera with a digital video camera. Digital video cameras used in fluoroscopy are either CCDs or CMOS light detectors. Both CCDs and CMOS convert the projection image of the output phosphor into a digital image and then a video signal. Both CCDs and CMOS have very small pixels of 10 to 20 microns in size and a matrix of at least 1000 by 1000 in an area of 2.5 centimeters by 2.5 centimeters squared. Larger matrix sizes are also available. Both have a linear response to light over a wide range. This is an advantage over analog video cameras that have a non-linear response to light. Video cameras using CCDs and CMOS are preferred over analog video systems because of their stability, reproducibility, and linearity. The table lists various advantages of CCDs over analog video cameras. In modern fluoroscopy systems, the image intensifier and video systems based on CCDs or CMOS cameras have been replaced by flat panel detector systems. Because of the high amplification electronics used with flat panel detectors, there is more electronic noise at low doses compared to image intensifier systems. In high dose applications like fluorographic acquisitions, electronic noise is not an issue. One way to reduce noise in flat panel detectors is to bin several cells together. Flat panel detectors are more compact because a thin film transistor array replaces the image intensifier, collimating lens, and camera systems we learned about earlier. This table shows a summary of flat panel detector advantages over CCD-based systems. Let's compare the performance of flat panel detectors to image intensifiers by looking at the quantum detection efficiency or QDE of both systems. The higher quantum detection efficiency of the flat panel detector gives it an advantage over an image intensifier system. These plots show the QDE measured at various kVs for a 20 cm patient thickness. QDE of the flat panel detector reaches above 90% at about 50 kV compared to the QDE in the mid 70% range for image intensifiers at about 60 kV. The image intensifier beam is harder because the image intensifier has 1.5 mm of aluminum between the X-ray source and the input window. Unlike image intensifier systems, flat panel detectors suffer from correlated noise and ghosting. Ghosting is the presence of a faint image of a previous acquired image. Correlated noise is due to the small deck cell size of detector elements. Correlated noise is corrected by binning multiple deck cells at a time to reduce noise. This, however, leads to lower spatial resolution. Ghosting may fade over time or can be removed by recalibrating the detector. Flat panel detector systems have a wide dynamic range and less lag than image intensifier systems. On this slide, we can look at additional comparisons between the image intensifier and flat panel detector systems. While image intensifiers have a circular field of view, flat panel detectors have rectangular field of views. Flat panel detector field of views are also larger and can be up to 20 inches compared to image intensifiers that can be as large as 16 inches in diameter. Images from flat panel detectors are also uniform with no pincushion or S-shaped distortions. Here is a comparison of the spatial resolution of a flat panel detector with that of an image intensifier at different field sizes. The flat panel detector performs better than the image intensifier at all field sizes as shown. Note that at smaller field sizes, which are magnification modes, doses will be higher for both systems. In fluoroscopy, contrast resolution is very poor because of the low MA used for imaging. This means the signal-to-noise ratio is low. Contrast is also affected by the dose settings and the patient size. With larger patients, there is more scatter, leading to lower contrast resolution. Fluoroscopy machines have various dose settings that allow the user to increase the exposure to improve the contrast resolution, especially for larger patients. In most fluoroscopy systems, an anti-scatter grid is usually installed, and that helps to improve contrast resolution. Grid ratios used in fluoroscopy are 6:1 to 12:1. Contrast resolution can be measured by a step wedge as shown in this figure. Let's look at a few other fluoroscopy configurations. Vascular and interventional suites are typically equipped with more powerful generators with higher heat capacity and water or oil-cooled X-ray tubes. Typical image intensifier sizes range from 28 to 40 centimeters. The system shown here is a biplane angiography system with one table and two complete fluoroscopy C-arms. It is capable of imaging in the AP and lateral dimensions simultaneously with single contrast injection. This means a reduced contrast burden for the patient. Pulsing of each plane is staggered, so scatter from one plane does not affect images from the other planes. Specific applications in interventional fluoroscopy include cardiac catheterization and electrophysiology. Cardiology suites can have single plane or biplane C-arms with A and B planes. These use high frame rates of 30 to 60 frames per second to display heart motion. Small image receptors are used to allow for more tilt in the cranial caudal direction. Some newer flat panel based cardiac catheterization labs incorporate larger image receptors for the primary or A plane, which makes possible adjunct imaging modes such as runoff imaging or rotational angiography. The B plane image receptor is sized for normal cardiac imaging. The second image shows a magnetic steering system for electrophysiology applications. Notice the flat panel detector is used with this system, so there is no effect on the image like S-shaped distortion because there is no free electron motion as in the II system. Another interventional application is in peripheral angiography. In peripheral runoff imaging, a bolus of contrast is followed as it travels from the injection site into the peripheral vasculature, most often in the legs. Many angiographic systems operate in a stepping mode for runoff procedures, sequentially stepping along the patient's body while acquiring images at each step. Images overlap by some extent, often one-third, to ensure smooth anatomical coverage. Compensating filters are often used to equalize image receptor exposure around the patient's legs. In this application, the table usually floats up, down, left, right, and head to toe. The C-arm has multiple degrees of freedom, allowing it to rotate and skew for various projection angles. Rooms usually have power injectors for iodine-based contrast. The image receptors can be large with 30 to 40 cm sizes for body work or small with 23 to 30 cm for neuro work. New systems have 3D imaging capability achieved by spinning the C-arm around the patient. R and F systems have both radiographic unit and fluoroscopy unit in the same room. The fluoroscopy X-ray tube is usually below table and the image intensifier or flat panel detector is above the table. The radiographic X-ray tube is mounted on rails in the ceiling. The table will have bucket trays for use with radiographic tube. These units are used for GI studies. The utility of this system is that the table and fluoroscopy system can rotate together. There are options for horizontal to head up or head down tilting. The tilting capability of the patient table allows the operator to utilize gravity to assist the movement of the contrast material through the esophagus, stomach, and bowel. The anti-scatter grade can be retracted with the push of a button to avoid overexposure of pediatric patients and when imaging thin or small anatomies. Genitourinary systems are used for voiding urograms. Often the X-ray tube is above the table and the image receptor is below the table. This configuration results in increased patient access but leads to increased radiation exposure for personnel compared to under-table X-ray tubes. Let's look now at some real-time imaging modes. We shall start with continuous fluoroscopy. Continuous fluoroscopy is the normal operating mode for most fluoroscopy systems. The MA ranges from 0.5 to 6 MA depending on the manufacturer. In some systems, 30 pulses per second is considered continuous fluoroscopy. When the pulsing rate is less than 30 pulses per second, the mode is called pulsed mode. Pulsed modes are lower dose than normal continuous fluoroscopy modes. In continuous fluoroscopy, at least 30 frames per second is used to ensure a smooth image with no flicker. The maximum entrance exposure rate in normal continuous fluoroscopy should be less than 10 roentgens per minute at 30 cm from the image intensifier. In variable frame rate pulsed fluoroscopy, the X-ray beam is pulsed on and off in short bursts with a pulse duration or pulse rate of between 1 to 10 milliseconds. Pulse rate may be variable, and common selections are 7.5 or 15 pulses per second. Other pulse rates are possible depending on the manufacturer. Pulsing reduces motion blur for moving anatomy like the heart, resulting in sharper images and improved image quality. There is also reduced tube loading because of a lower duty cycle. A low frame rate selection reduces radiation exposure but also reduces temporal resolution of moving organs. Higher frame rates may be combined with pulsing in this situation. Various combinations of pulsing rates and frame rate selections are available depending on the manufacturer. Low pulse rates and low frame rates give low dose than higher pulse rates and higher frame rates. High dose rate fluoroscopy is also called high level control. This mode allows patient entrance exposure rates above the 10 Röntgen per minute limit for reduced noise and increased penetration when imaging larger patients. The MA can be as high as 20 milliamps in some cases. This system is limited to 20 Röntgens per minute patient entrance exposure rate and requires special means of activation different from standard fluoroscopy. Like all fluoroscopy systems, it requires continuous manual activation. It also requires a continuous audible signal while the high-level X-ray beam is activated. In some applications in the operating room, a C-arm can be used to acquire tomographic images of screw placement or hardware within a patient. Having this feature on a C-arm is convenient because the patient does not have to be moved to the CT scanner to acquire 3D images. The O-arm, which was introduced in 2006, also has the capability to acquire both 2D fluoroscopy images and 3D tomographic images with one imaging machine. The images acquired by 3D C-arms and O-arms are not true CT images because there is no Hounsfield unit associated with the images. Both O-arms and 3D C-arms use flat panel detectors with a wide area, so they require special reconstruction algorithms because the beam is shaped like a cone. Let's now look at some image processing applications. We shall start with frame averaging. An important attribute of fluoroscopy imaging is excellent temporal resolution. But because fluoroscopy uses very low MA, the images are relatively noisy. One way to reduce this quantum noise is to combine multiple frames in a process called frame averaging. In this approach, a series of video frames are averaged together and displayed. While this reduces image noise, it also increases the appearance of lag, particularly with fast-moving, high-contrast objects. The bottom figure here shows figure A with 5 averaged frames, figure B has 10 frames, and figure C has 20 frames averaged. The moving structure in the center of the images shows noticeable blurring due to lag as more frames are averaged. Last image hold is a technique used to reduce patient radiation exposure. After fluoroscopy is stopped, the last video frame is stored in digital memory and continuously displayed on a second monitor. This feature allows for prolonged study of the image without continuous radiation exposure. The image can also be saved as a digital photo spot. Digital subtraction angiography is used to improve visualization of contrast-filled vessels. In vascular studies where iodine contrast injections are used, images that include a contrast agent can be subtracted from the mask image of the anatomical background to remove overlying bone and soft tissue. The subtraction reduces anatomical noise and increases the contrast of blood vessels in the subtracted images. Contrast differences of less than 1% can be observed. Signal in the contrast-filled vessels depends only on the amount of contrast in the vessel and not on the background. The drawback is because the noise level in subtracted images is higher, DSA requires more exposure than digital fluoroscopy acquisitions to maintain image quality levels. Figure C shows a DSA image obtained by subtracting the pre-injection and post-injection images shown. Road mapping is an imaging mode used to create a map of vascular anatomy that aids the navigation of catheters. A road map can be generated in two ways, either by using a stored image of a contrast-filled vessel or in a more complex fashion by using the peak opacification in each image pixel obtained from a series of post-injection images. The roadmap image can either be displayed alongside a live image on another monitor or overlaid on the live fluoroscopic image. Road mapping is a video-enhanced version of last image hold, so it provides the same level of dose savings. Fluoroscopy, particularly in interventional procedures, can give rise to both stochastic and deterministic effects. We shall focus on deterministic effects from fluoroscopy procedures, particularly patient skin dose. Dosimetry indicators for skin dose can be direct and in real time or indirect. Direct indicators of skin dose are cumulative dose readings of the display console and Kerma-area-product readings or dose-area-product readings. Indirect methods involve using TLDs, OSL, or semiconductor detectors attached to the patient's skin during the procedure and reading of the dose to the skin. Also, radiographic or radiochromic film can be used for indirect indication of skin dose. Fluoroscopy time is commonly used as a surrogate for patient dose, as it is widely available on fluoroscopy equipment. It is far from ideal because it ignores many large contributions to patient dose, including digital acquisition imaging. Digital acquisitions like cine or record modes or DSA imaging are frequently the largest contributor to patient dose during fluoroscopy procedures. The next direct method is to use the dose area product DAP or Kerma-area-product KAP meters. A DAP meter is a device placed at the collimator location to measure radiation output from the tube. The figure shows the placement of the DAP or KAP meter after the collimator. DAP meters are independent of SID due to the use of automatic gain compensation or AGC on fluoroscopy machines. While KAP is an ideal quantity for assessing stochastic risk, it has limited application as an indicator of skin dose. However, when carefully combined with direct skin dose measures, it has been used to determine the trigger levels for specific procedures to alert operators of the possible danger of skin damage. Cumulative dose refers to the cumulative air Kerma at the interventional reference point IRP at any time during a fluoroscopy guided procedure. It is also called a reference point air Kerma. The IRP is a point 15 centimeters toward the focal spot from the isocenter, and its location does not vary with changes in C-arm angle or focus to image distance. There are state and federal regulations governing maximum entrance exposure rates. Maximum fluoroscopy entrance exposure rate should be less than 10 Röntgens per minute in normal mode or 20 Röntgen per minute in high dose mode at the point where the center of the useful beam enters the patient. This point is standardized to be 30 centimeters from the surface of the image receptor. The cumulative dose as a direct method is the quantity most closely correlated to skin dose in fluoroscopy guided procedures, as all contributions to skin dose from both fluoroscopy acquisitions and cine recordings are included. Once we know the cumulative dose, we can use that to determine the peak skin dose or PSD. This refers to the highest dose to any single area of a patient's skin. In practice, accurate PSD determination is challenging. An important consideration is that the cumulative dose is measured at a point in space that may not coincide with the patient's skin surface. Even if the IRP is located exactly on the patient's skin surface, backscatter will increase PSD beyond the displayed cumulative dose by between 30 to 40%. Let's finish up with a few questions. First question: which of these is not a direct indicator of patient skin dose in fluoroscopy? Your choices are A. DAP, B. Cumulative dose, C. KAP, D. TLD. The correct choice is D. TLD. Next question: which of these statements is not true about peak skin dose? Your choices are A. It is highest dose to any point on patient skin. B. Backscatter has no influence on PSD and can be ignored. C. Accurate PSD is difficult to determine. D. Should be equal to cumulative dose if backscatter is not included. The statement which is not true is B. Backscatter has no influence on PSD and can be ignored. This is the last slide. Thank you for watching this presentation.